before to kind of a small service for my acute pain service. But as Chris said, it is a very interesting and not very well known or even really well researched topic. But I still wanted to have a nice kind of discussion an overview of kind of the literature and what we have seen with some of these skeletal muscle relaxants. I'm also hoping maybe we can have some engagement too, since a lot of the things that we use for skeletal muscle relaxants are based off of anecdotal evidence and kind of practices. So I'm curious what everyone else is doing with skeletal muscle relaxants so we can all kind of learn from each other, hopefully. So as just an overview of kind of what we'll be going over, we'll be looking at the differences actually between spasms and spasticity. So they are two different kind of pathophysiology. So it'd be good to kind of review them, or what we know of them at least. Hopefully identify some medications that can be used to treat either spasms and/or spasticity. Discuss some of the clinical pearls, dosing strategies, things to know with each of the muscle relaxants, and then review some compelling indications for utilizing specific antispasmodics or skeletal muscle relaxants for specific patients. So this is a nice little chart I put together about the differences between spasticity and muscle spasm. So really here, they kind of have two very distinct pathophysiologies from what we know of, at least between them. Spasticity seems like it's much more well researched than muscle spasm specifically, so we know a little bit more about it. But specifically for spasticity, we see this increase in the muscle stretch reflex excitability, and this is actually due to these motor neuron changes that occur. So what we think with spasticity is these are really neurologic type conditions or pathophysiologies in nature. As opposed to muscle spasms, this is really actually an involuntary contraction of muscle groups, and this occurs secondary to musculoskeletal conditions. So we think of like sports injuries or something that could cause muscle spasms, surgeries, traumas, actual injury to the tissues and the muscles are what causes the muscle spasm here. So it doesn't really have to do with any motor neurons, no neurologic type conditions here. Between both, we see GABA, glutamate, and glycine kind of play a role. Acetylcholine as well. GABA, glutamate, and glycine all are either excitatory or inhibitory. GABA inhibitory, glutamate and glycine excitatory. They kind of go into the development of spasticity and maybe some of the motor neuron firing that we see. So we think that they're more associated with spasticity, but that we think that acetylcholine has a role to play actually in muscle contraction as well. So we think that's also associated in both muscle spasms and spasticity. So with our associated pathologies with spasticity, these are the neurologic conditions that we think of: multiple sclerosis, cerebral palsy, traumatic brain injury, and spinal cord injury. So there's actually an insult and an injury to the nerve and the central nervous system that is causing the spasticity to be kind of uncontrolled, and it can be very painful for some patients. With muscle spasms, as I said earlier, musculoskeletal pain, low back pain, having a herniated disc, even fibromyalgia, which, we're still not fully aware of that whole pathophysiology, but we think is more associated with muscle spasms, even though maybe there is some role of spasticity there. For symptoms, specifically with spasticity, we see stiffness and hyperreflexia, as opposed to with muscle spasm, that's where you see the twitches, the cramps, the muscle jerks. Patients could really point out, oh, my muscles feel like they're really spasming, like they're contracting very rapidly, is kind of what we're seeing. So for spasticity, I thought, because I'm a visual learner, putting in a picture would kind of be helpful. So starting on the left, you have your muscle, specifically the muscle group, and it's initially stretched, and this sends the afferent signals actually directly to the spinal cord. And in here is where the inner neurons actually connect the afferent and the efferent fibers. So a lot of that processing and a lot of the neuronal communication happens within those specific fibers. And then with 4, the efferent signals are sent to the muscle to cause contraction. So what happens is with spasticity, we have changes in motor neurons. So there's a low level of baseline presynaptic inhibition. And then in conjunction, there's a reciprocal inhibition of the high stretch reflex activity. So spasticity is really caused by a lack of inhibition of the afferent signals, and then an increased excitation of signals sent to promote muscle contraction. So you're not inhibiting as much, as well as you're actually causing more of those signals to be sent over back to the muscle groups. So here there's no tissue injury, and this is really where the pathophysiology is based on the neuronal changes and the motor neuron changes here. With muscle spasms, I had a really tough time kind of finding why muscle spasms are caused. And it seems like there is really no great literature showing or even explaining the pathophysiology of musculoskeletal spasms. So this picture that I found here is just one of the kind of proposed theories that we think is causing some of the musculoskeletal spasms that we do see in some patients. And this here is called the pain spasm pain cycle. And this kind of outlines one of the pathophysiologies that we think about. So what we think is that the tissue injury is really what starts to cause this cycle going on. So this tissue injury leads to nociceptor activation. You then have a pain stimulus, so that gets carried to the spinal cord, and from the spinal cord travels where that, it kind of goes through the whole pain processing pathway with modulation and perception. But then the neurotransmitters then go back down through the spinal cord, and this causes the muscle spasm. The problem here then is that the muscle spasm and the tone actually further increases tissue damage. So this tissue damage then gets you back to the square one where you're back at tissue injury, and you have this pain cycle, pain spasm, where the spasms cause more pain, the pain causes spasm over and over and over. So this was one of the ones that I thought kind of makes sense, but it seems like within the literature, some people are saying that it doesn't fully work out as to one of the proposed mechanisms really why spasms occur. But I kind of wanted to take a second to hear if anyone else has heard any of proposed theories for the pathophysiology of muscle spasms, since there is no real consensus on it. Okay. And that silence, I think, kind of echoes that we're not really sure, or we kind of just think that it happens due to tissue injury, but we don't really know exactly what's going on, I think. So what medications do we use for skeletal muscle or for muscle relaxation, and which ones actually treat what we are trying to treat? So there's two categories of skeletal muscle relaxants. You have our antispasmodic agents and you have our antispasticity agents. So thinking back to the pathophysiology as to whether we're treating spasticity or whether we're treating muscle spasms, we need to use the correct medication in order to actually treat the correct condition that our patient is experiencing. So for antispasmodic agents, we have things like carisoprodol or soma, cyclobenzaprine, metaxalone, methocarbamol, orphenadrine, and chlorzoxazone. But antispasticity, we have baclofen and dantrolene, specifically for spasticity. Now, within kind of both, diazepam and tizanidine actually work as antispastic and antispasmodic agents. So if you see these medications, you know, okay, there could be one of the other of the conditions that we're actually treating, but you want to make sure that we're giving the medication that properly aligns with the actual symptom that our patient is having. So looking at our actual indications for skeletal muscle relaxants, the literature at least really promotes using this for a very short term, only 2 to 3 weeks of relief for muscle spasms or tenderness that's specifically related to certain conditions. So not all conditions, but mechanical neck and low back pain is one of them, fibromyalgia, myofascial pain syndromes, and then also multimodal analgesia and trauma or surgery patients. So it's kind of interesting here because some of the guidelines have shown that short-term therapies such as cyclobenzaprine for a few weeks can really help with low back pain. Cyclobenzaprine is also one of the guideline recommended medications for fibromyalgia. And then for the multimodal analgesia, there isn't really a whole lot of great literature actually looking at specifically skeletal muscle relaxants. They just know that as part of a whole multimodal analgesia plan, they actually help kind of decrease MMEs or oral opioid consumption overall. There has been some recent literature actually looking at methocarbamol specifically in rib fracture patients in trauma that have had some pretty good efficacy in some patients. So that's why they're kind of thinking, okay, maybe we can get more of the skeletal muscle relaxants throughout more of our multimodal analgesia trauma patients. It is kind of interesting to note, I did find 2 randomized placebo-controlled trials of adding a skeletal muscle relaxant, whether it was methocarbamol or metaxalone, tizanidine, or baclofen, to NSAIDs for acute low back pain in the ED, and there actually was no significant improvement in pain there. So you kind of have to be really careful and judicious with the muscle relaxants you do use. They're kind of, it seems like there isn't a great way to integrate them for every single patient, but knowing kind of our symptoms for our patients can be helpful. So how do we actually know what we need to choose or which medication we actually choose? The thing is, there is really no data showing that one of the skeletal muscle relaxants is superior to another skeletal muscle relaxant, and specifically within the antispasmodics. So cyclobenzaprine will be just as efficacious as methocarbamol, which will be just as efficacious as metaxalone, and so on. So what we're thinking is that in order to actually choose a medication that will be helpful for a patient, we need to consider kind of all of the facets of the medications. So what are our agent or patient-related variables? We're looking for side effects. We're looking at the drug interactions that they cause. How are the patient's renal or hepatic functions? What cardiac comorbidities do they have? And then patient response. So are they actually responding to the medication we give? Did they not have an adequate response? Should we rotate therapy? And then it also always thinking about our non-pharmacologic options. So it's really recommended heat or cold therapy for painful muscle spasms can be extremely helpful, as well as massage therapy. So even though there aren't things that we specifically can do, it's still good to recommend these for our patients. So opening up this question to everyone else, with skeletal muscle relaxants, what are our most common side effects, and what do we need to really worry about with skeletal muscle relaxants when we actually recommend these for our patients? Anyone can unmute and say, or, oh, I have not been checking the chat. Okay. Sedating side effects. Yeah, I definitely agree that is one of them. Anyone else have something that they think about, like, oh, we need to check this anticholinergic? Yep, totally right. That is a big one I think of as well. Okay. So the things that I like to really consider and always think about is all of them increase the risk for delirium. This is kind of shown within the literature that we know that some of our patients may be at a predisposed risk for delirium, such as our surgical patients that we use. And of course, they have a lot of other concomitant medications for treating acute pain or even chronic pain that could put them at the risk for delirium. But we know that all of them can have an increased risk for causing delirium. And especially, as Emily pointed out, the ones with anticholinergic effects have a more significantly increased risk for precipitating delirium. So considering something else, all are considered Beer's criteria besides tizanidine, and I kind of don't fully agree with tizanidine not being a Beer's criteria list. And we'll talk a little bit about why I disagree with that. But so they all increase the risk for falls. And again, this could be going back to their anticholinergic effects, their sedating effects, even if it's not anticholinergic, as well as kind of their drug interactions with other sedating medications that can cause further sedation. They have a 40% increase in the fracture risk. So it's kind of interesting because the study that they actually based this off of was a case control study, and they actually included oxybutynin in their antispasmodic agents. So they included kind of the smooth muscle relaxants as well as the skeletal muscle relaxants for here, and oxybutynin actually accounted for the vast majority of fractures that we're seeing. But they didn't do any analysis without oxybutynin. They also had patients in the group that were receiving antispasmodics had a significantly higher incidence of dementia. So another thing that could be contributing to fracture risk. And then a 35% increase in injury risk. And when you see it, that's a very high injury risk. But when you look at the absolute values and the numbers, the number needed to harm was about 333. So still a very high chance that, these patients aren't going to have a very high injury risk just compared to not having them. They might have a slightly increased risk for having it. So when I was completing this, the reason that I kind of wanted to look at these is because I noticed that we are using so many skeletal muscle relaxants for post-operative pain and specifically post-operative spasms. So my recommendation usually is to avoid scheduling skeletal muscle relaxants because they can be so sedating, they can be deliriogenic, they could also contribute to sedation, which doesn't allow patients to ambulate, get out of bed, progress further in their post-surgical status. And then provide patient and nursing education on actually PRN use. So actually asking for the medication when they need it and if they need it. But if you notice the spasms are recurrent, they're happening a lot, they're tolerating the adverse events and they're actually getting efficacy from the skeletal muscle relaxant, then consider scheduling it at that point, making sure that we're still monitoring our patient, but understanding, okay, we want to make sure that this patient is more ambulatory, they're able to participate in PT. Can they still hit these goals even if we schedule our muscle relaxants? So for the first active learning question, it's just kind of wondering which of these is not considered an antispasmodic. Would it be diazepam, cyclobenzaprine, baclofen, or methocarbamol? And this is really thinking back to what medications are antispasmodics and which ones are antispastic agents. Again, feel free to unmute or you can just put it in the chat, your answer. A, JK. C. Okay, I agree. So I put C as the right answer. So it was a little confusing, and Emily, I see that you had taken back your original answer because diazepam, it's both an antispasmodic and an antispastic agent. So it fits into both categories. So it is confusing because it is an antispastic and you're like, oh, is it an antispasmodic too? But it would be both. But baclofen is more strictly an antispastic agent. Yeah, sorry. Didn't mean for the negative. I know that's one of the things they tell you not to do when you're asking a question. So cyclobenzaprine or Flexeril. This is a medication that is very well studied, at least comparatively to the other skeletal muscle relaxants. This is really kind of our gold standard skeletal muscle relaxant that we think of. But there really are a lot of considerations that we need to think about when we are utilizing or recommending cyclobenzaprine for our patients. So the mechanism of action, it actually inhibits the alpha and gamma brainstem motor neurons, which in return actually works to help decrease the muscle spasms that are kind of part of the cycle. But I wanted to point out that it is an amitriptyline-like compound. So if you look at the picture on the right, you can see cyclobenzaprine on the top and amitriptyline on the bottom. And the only difference is that double carbon bond between 9 and 10. So it is an extremely structurally similar medication to amitriptyline. So we need to think of kind of drug interactions and other adverse events kind of like TCAs when we're thinking about this medication. So for dosing, the most common dosing is 5 milligrams by mouth 3 times a day, and you can increase it up to 10 milligrams 3 times a day. What I recommend is always starting at 5 milligrams. There actually was a randomized controlled trial comparing 2.5 to 5 milligrams to 10 milligrams for painful muscle spasms. And this was over a couple of weeks. And they found that the 5 milligrams was actually equally as effective as the 10 milligram dose. And you're getting less of that sedation effects from the 10 milligram dose. So I always say start with 5. The onset for cyclobenzaprine is about 1 hour and it peaks at about 4 hours. What's really interesting is if you actually look at the duration within the package insert or any of the drug databases online, the duration is actually 12 to 24 hours, even though we dose it 3 times a day. So that's why I like to recommend sometimes the PRN doses first as well, is because sometimes patients will get a much longer effect of the antispasmodic agent than what we actually see in dosing or in practice. For any renal hepatic considerations, always reduce the frequency to daily in elderly patients. The reason for this is because our elderly patients have this large decrease in hepatic blood flow, they think that cyclobenzaprine is significantly less metabolized by our elderly patients. So you get the cyclobenzaprine hang around for a lot longer, like significantly longer, so they only can use daily dosing. Because if you use a more frequent one, then you get the dose stacking, you get a lot of this sedation effects and the anticholinergic effects. They also recommend to avoid it in any moderate or severe hepatic impairment, again, due to the metabolism, and then caution in mild. Cyclobenzaprine is mostly excreted by kidneys as its glucuronide metabolite, so you're not too worried about too much of the renal extraction or renal elimination. For adverse events, dizziness, drowsiness, dry mouth, constipation, urinary retention. So those are like the biggest anticholinergic ones. And that's the thing with cyclobenzaprine. Just like the TCAs have very strong anticholinergic effects. So that's why you get a lot of the sedation, you got an increased risk of falls, increased risk for delirium. So be very careful in patients that are more sensitive to anticholinergic medications. Cardiac arrhythmias is an extremely rare. I really couldn't find too much in the literature, but it's in the package insert, just kind of saying, oh, because it is so structurally similar to TCAs, you could have some rare adverse events or potential adverse events, such as cardiac arrhythmias, QT prolongation, and then also you can see some possibility of an overlap with serotonin syndrome in some medications or with some medications. So for clinical pearls, one of the things that I think about is in pregnant patients. This actually is, well, I guess it's not anymore because they changed their pregnancy categories, but it was category B. It had no association with birth defects, any miscarriage or adverse fetal outcomes. So it was, or I guess it is safe to use in our pregnant patients. And then as I said before, the 5 milligram dose is as effective as a 10 milligram dose. One of the other things I do have just as a note is that it may have a risk to decrease seizure threshold, but that's a very, very rare and just kind of another theoretical risk. So just something to be mindful of. So methocarbamol is the next one that we'll be talking about. And as you can see on the right, methocarbamol is actually a guaifenesin derivative, even though it has none of the same kind of real overlapping effects with guaifenesin. It's not an expectorant. And we actually really don't know how methocarbamol particularly works. So originally it was thought just because it has some significant CNS depression, it actually causes a decrease in synaptic action, leading to less muscle spasms. But they're still not fully sure about that. And there was actually a 2021 study that did a little bit of the pharmacology on methocarbamol and found that it actually had a decrease on the NaV 1.4 receptors, which decreased the actual action potential in skeletal muscles, but this was in mouse models. So I think they're still trying to work out exactly how methocarbamol even works. For the onset, you see it within 30 minutes. The duration isn't really well defined, even though the package insert for the IV formulation says 24 hours, but I don't think I've ever seen Relaxant actually last 24 hours in any patient. And it peaks within 1 to 2 hours. So for dosing, it's pretty interesting because I don't think I've ever seen the loading dose for methocarbamol actually given, but what it recommends is to give 1,500 milligrams by mouth 4 times daily for 2 to 3 days, and then you decrease to about 750 to 1,000 milligrams between 3 times a day and 4 times a day. So mostly what I say is the second half where it's 750 to 1,000 milligrams TID to QID. So I'm not exactly sure specifically in practice how much that translates, missing that initial loading dose. Again, something really important to actually note for this is the oral and the IV formulation actually have different recommended dosings. So the IV formulation is actually supposed to be given as 1,000 milligrams IV every 8 hours for only a maximum of 3 days. So don't give it 4 times a day and don't give it any more than 3 days. So there's actually, it's formulated with polyethylene glycol within, it's the vehicle for the IV formulation. So that's why they say 3-day limit. And you have to go at least 48 hours in between 3-day stretches of Relaxant in order to get another 3-day dose of Relaxant or 3-day regimen. There's no dose adjustments that are actually needed for renal or hepatic impairment, but you do need to avoid the IV formulation in moderate or severe renal impairment due to that polyethylene glycol that's in it. Also, it is important to note that while there are no adjustments that are recommended, methocarbamol clearance is decreased by about 40% in severe renal impairment and by about 70% in hepatic impairment. So even though we don't dose adjust, be careful of using these medications because it may actually build up. So we need to make sure we're monitoring our patient. Kind of similar to cyclobenzaprine is what we'll see with basically all of the skeletal muscle relaxants. You can see dizziness, you can see drowsiness, can cause dry mouth, dyspepsia, and nausea. But one of the things that I always think about with methocarbamol specifically is that it actually does not have any anticholinergic activity. So it is still sedating. And if someone says that it's not sedating, I don't know if that's fully true, but it is the least sedating of the skeletal muscle relaxants that are currently being utilized, at least right now. I think one of the other things to think about with it as well is that when you're counseling a patient and they notice maybe their urine or their stool is a black or brown or green color, that's one of the effects that you can see with methocarbamol administration. So just making sure that you're aware of these kind of unique adverse events or, strange things that patients are like, oh, why is my poop green kind of thing. Metaxalone is the next one that we'll be talking about. And again, kind of like a lot of the things that we see with these skeletal muscle relaxants is we don't really know exactly how it works. They think it's myelorelaxation secondary to sedative effects. At least that's what they say in kind of the package insert and the drug databases. But they did a different group did a study in 2020 that found that metaxalone actually decreases inflammatory cytokines in vitro. And they think that that somehow has a role in its muscle relaxant effects, which I think is really interesting. Kind of similar to the other medications, it has an onset of about an hour and a duration of about 6 hours. It peaks at about 3 hours and the half-life is about 8 to 9 hours. So just kind of thinking of when you'll get the best effects from it. And it's generally dosed as 800 milligrams 3 times daily to 4 times daily. So no loading dose needed. You want to avoid it in any severe renal or hepatic dysfunction. It's metabolized by the liver, and we actually don't even know the metabolites that it's metabolized to. So that's why we want to caution in liver impairment. And then it's excreted by the kidneys. Those metabolites and metaxalone are excreted by the kidneys. So being careful here as well. Well, for adverse events, dizziness, drowsiness, and GI upset are there. There may be more adverse events, but it's not a very commonly used medication. So I don't think there's a whole lot of research on exactly all of the adverse events associated with metaxalone. What's interesting here is that food actually increases the bioavailability. So we want to make sure if we're giving it to our patients that they take it consistently with or without meals. And if they have failure with some doses, but not with other doses, kind of understanding how did they take it? Are they taking it with food every single time? Can we kind of optimize that as well? One of the other things with metaxalone is the bioavailability actually increases with the age of our patients. So when elderly patients are taking metaxalone, they may have a much greater effect from the dizziness and drowsiness. And then when they're also, taking it with food, they might actually also be getting it at much higher increased doses when they're not taking it without food. One of the things that I haven't seen in practice particularly, but it's kind of cautioned here, is that paradoxical cramps can occur even though they're very rare. But overall, it's a pretty well studied medication. And then kind of similar to cyclobenzaprine, there is some concern for serotonin syndrome, maybe one of the possible side effects that you can see with metaxalone. But again, very rare. Tizanidine is the next medication. So this one, as we can kind of remember, is both an antispasmodic agent and an antispastic agent. So what it does, it's an alpha-2 agonist, as we probably all know, but this results in presynaptic motor neuron inhibition and also results in a decrease in glutamate release. So we are hitting both spasm and spasticity. We're blocking both glutamate, we're blocking motor neuron, or we're causing motor neuron inhibition. So we're actually getting both of the disease states and pathophysiologies kind of covered there. It peaks within 1 to 2 hours and lasts for about 3 to 6 hours. And one of the things is with capsules and tablets, you'll see in the clinical pearls, that first one, they're not equally bioavailable when given with food. And specifically, the capsules have a decrease in bioavailability of about 75 to 80%. And also their Tmax is significantly prolonged. So when the capsules are given with food. Their peak effect is in about 3 to 4 hours, so not that 1 hour that we see with tablets. For dosing, tizanidine usually starts around like 4 milligrams by mouth every 6 to 8 hours, up to a max of 36 milligrams per day. It's really something that you want to be cautious here with patients because tizanidine can have some really significant interpatient variability in serum concentrations. So dose finding is really kind of recommended initially if patients are way too sensitive to the 4 milligram dose, even or at Q6 hours. Back off on the dose, increase the frequency between the medication. Just make sure that we're using kind of individualized therapy for tizanidine because it can result in some very big differences in serum concentration. For renal impairment, you want to start with 2 milligrams daily in severe renal impairment. So there's different dosing strategies that you can give between the different levels of renal impairment, but I put the most severe one here, 2 milligrams daily, to kind of give you guys a sense of how low do you have to go for patients that don't have any renal function, or for patients that really need this medication, but they're on dialysis. So make sure you start very low for patients with renal dysfunction. It's recommended to avoid in hepatic impairment. It's metabolized by CYP1A2. Sorry, I forgot, but cyclobenzaprine was also metabolized by 1A2. So they're recommending just to avoid it in some significant hepatic impairment because it can result in, again, increased tizanidine concentrations. With adverse events, you can see a lot of the similar ones: dry mouth, somnolence, hypotension, asthenia, LFT elevations. And this is kind of one of the reasons why I think it should still be on the Beers criteria. You can get somnolence, and the orthostatic hypotension that can occur with tizanidine can put our elderly patients at a significantly increased risk for falls, fractures, just other problems. So I still think that even though it's not particularly on the Beers criteria, I would still consider it something to use a lot of caution with in our elderly patients. What I thought was also pretty interesting with tizanidine is that when tizanidine is used chronically, it actually can cause QT prolongation. So not something that you normally see in the acute phase. You don't have to be worried about it if someone's in the acute phase and you want to give them tizanidine, but with repeated dosing over 2 to 3 weeks and at the higher dosing range, they actually found that QT prolongation was something that was kind of a little more common in patients, but not still very common. And they actually found it was more common in women than in men as well. So we talked about capsule bioavailability and then withdrawal syndrome. So kind of similar to any of our alpha agonists that we think about, if patients are taking tizanidine for very frequent doses, high doses for long periods of time, so over 2 to 4 weeks, they can have this rebound effect of the tachycardia, hypertension, tremor, anxiety, and hypertonicity. So making sure that if we are taking our patients off tizanidine, we are slowly tapering them and making sure that we're treating any of the effects of withdrawal if they have them. And as I said here, it's considered the skeletal muscle relaxant of choice in older adults, but it's still something that you definitely need to use caution for. So one of the questions that I kind of had with this medication as well was, what about clonidine? What about guanfacine? What about dexmedetomidine? And I tried to look for evidence, and there was some evidence kind of from the 1980s and 90s for the treatment of spasticity for clonidine in spinal cord injury patients. So clonidine may be something that you could try and use, but doesn't have as much evidence as tizanidine. And then I found just one case report of dexmedetomidine and this was just done in 2022, that actually decreased some painful muscle spasms for an ICU patient. So not great evidence, but still things, if we want an alternative, maybe we could try. So next is moving on to diazepam. So this is our GABA agonist. I'm sure all of us are very well aware of benzodiazepines, but it actually causes chloride shifts to inhibit synaptic activation in the spinal cord. So with diazepam, what we see is that the oral medication peaks in about 1 to 1.5 hours, while the IV peaks in about 8 minutes. The oral has a very high bioavailability, so they're 1-to-1 in regards to their dosing strategy. And the duration is thought to last maybe about 12 hours. I didn't really get too great literature actually showing how long diazepam's mechanism of action is specifically for muscle relaxation. But based on kind of the metabolism, the metabolites and diazepam, we would think it could last up to 12 hours in some patients. but it can be dosed more frequently in some patients if they have recurring muscle spasms. They recommend avoiding any IM administration, can have a lot of erratic absorption and a long time to peak. For dosing, usually start on the lower end with diazepam unless patients already have a tolerance to benzodiazepines. So what I usually recommend is 2 milligrams by mouth or IV about twice a day to 3 times a day. Now they say you can go up to a max of 40 to 60 milligrams per day, but that's on the very high end of patients that are having a lot of muscle spasms that are completely refractory to these lower doses of diazepam or even other agents. For renal and hepatic considerations, you want to avoid an hepatic impairment. So diazepam is extensively metabolized by both 3A4 and 2C19. It also has a high amount of protein binding. So something to consider with some of our other medications that may have high protein binding that could cause more free diazepam throughout the serum. The metabolite desmethyl diazepam also has a half-life of up to 100 hours and can be significantly more prolonged in any patients that are taking 2C19 inhibitors or that have hepatic impairment. So making sure that we're very aware of our drug interactions and our hepatic function. It also is very lipophilic and it accumulates with repeated dosing, which also further prolongs the half-life. So making sure that we have caution the longer that patients stay on it and the more frequent that patients receive this medication. As with other benzos, we can see dizziness, dependence, paradoxical excitation, and delirium as our common adverse events. And just like other benzodiazepines, it can induce withdrawal symptoms if it's used chronically. But because of the long half-life, a lot of protocols will use this for alcohol withdrawal or other type benzodiazepine tapers because of the long half-life, so it allows for a more gradual decrease in medication dosing. Kind of similar to the thoughts on tizanidine, I looked at lorazepam, alprazolam, clonazepam, other benzodiazepines for the management of muscle relaxation, at least from benzodiazepines, and I couldn't find any literature saying any other benzodiazepine besides diazepam works. So what I had heard when I had kind of brought this up to some other of my colleagues is that because diazepam has a long duration and a long half-life, that's kind of why they went with diazepam as being studied for muscle relaxation, because they thought it would last a long period of time. But I couldn't find any reasons why lorazepam or alprazolam would not work as muscle relaxants. Okay, so carisoprodol is the next one, and it works by modulating the interneuronal activity in the spinal cord and also leads to some of this decrease in polysynaptic neuronal transmission. So it has an onset of about 30 minutes and peaks at about 4 hours, and they think that it lasts about 4 to 6 hours for a single dose, but it really differs kind of based on patients and what feeling they're actually feeling. So carisoprodol itself is thought to have a half-life of about 2 hours, but it has this metabolite, which you can see under the first bullet of clinical pearls, that's a barbiturate-like compound, mipropramate, and that has a half-life of about 10 hours. So they're really different in kind of how long they last in the body, their peak effects, because carisoprodol also peaks in about 1.5 hours, but mipropramate peaks in about 4 hours. So we need to be really careful in patients because they're getting both of these compounds, mipropramate and carisoprodol. They're both sedating. They both can have a lot of these other kind of effects. So we need to be careful and think about, clinically, what are we seeing and which peaks is the patient getting, and is that correlating with the kind of clinical effects that we're seeing. For dosing, it's dosed about 250 to 350 milligrams 4 times daily. And you want to avoid it in any severe renal or hepatic impairment and have any caution in moderate renal or hepatic impairment. And that's because carisoprodol and mipropramate are excreted by the kidney, and carisoprodol is extensively hepatically metabolized through 2C19 to its barbiturate-like compound. It has a chance to cause dizziness, drowsiness, and headache. And I think with this medication, because it does have the barbiturate metabolite, that dizziness and drowsiness can be pretty significant amongst patients. I didn't know this before, but carisoprodol actually has a chance to cause iatrogenic reactions such as altered mental status, transient quadriplegia, and temporary vision loss. And that's just with a single dose it can cause it. So it's not saying that this will happen with patients. And I found that it was extremely rare for it to occur, but it may have iatrogenic reactions that would be reversible. So just something to look out, when patients are first getting this medication, are they going to have this reaction? Make sure someone is monitoring that. And then baclofen. So baclofen is our antispastic agent. It is a GABA B agonist, and this inhibits synaptic glutamate release in order to actually prevent some of that motor neuron firing that we see in our spastic agents. What is also interesting is that intrathecal baclofen may help decrease neuropathic pain. And it's something that we're not really sure exactly how it helps for neuropathic pain, but some of the theories are inhibition of substance P release, or some changes in pain processing and the pain processing pathway that can lead to antinociceptive effects, at least for neuropathic pain. The thing is, we don't see this specifically with oral agents because the dose necessary to actually cause this type of pain relief and this neuropathic inhibition can't be achieved without these significant systemic adverse events. So intrathecal is really the only way to get the kind of effects that we need without getting to the significant amount of side effects. It peaks within an hour, but it ranges between patients between 30 minutes to 4 hours. So it's kind of up in the air how long it really will take to kick in. But so the dosing for the oral is 5 milligrams 3 times a day, up to a total of, or up to a max of 80 milligrams per day. And for the intrathecal pump, what I found is that it was between about 90 and 100 micrograms per day via the intrathecal pump, but it really requires a specialist in order to get it started. There's test doses for the intrathecal baclofen that need to be done. So that needs to be managed by a specialist. For renal and hepatic considerations, what's generally recommended is, because baclofen is renally excreted, to reduce the dose by about a third in mild, reduce the dose by half in moderate, and reduce the dose by 2/3 in severe renal impairment, because it is excreted about 70% unchanged in the urine. For adverse events, one of the most common ones that I hear all the time and see is urinary retention. Can cause some other weakness, can cause dizziness, sedation, vertigo, insomnia. So a lot of things that we still need to consider for our patients. And in the post-op period, making sure that we are still kind of like with the other ones, making sure they're still able to participate in PT. For our clinical pearls, can cause withdrawal syndrome, kind of similar to what we see with our other GABA agonists like benzodiazepines, cause confusion, hallucinations, seizures, if it is withdrawn too quickly and if it's at a high enough dose for a long enough period of time. So kind of similar to what our benzodiazepine literature says, is to reduce the dose by about 10 to 25% weekly if used chronically. So I did want to ask the group, just because I'd like to hear other points of view as well, but what have you used baclofen for, or what have you seen baclofen actually used for besides spasticity? Have you seen it used for certain pain syndromes? Hiccups. Yes, that is true. I was actually just looking at hiccup literature today, and I saw baclofen has been used for it. That's a really good point. Have you recommended it for a patient that's actually worked, Emily?
Oh, we've had a few patients on our hospice service that we have used it in with success.
Cool. Good to know. Definitely keep that on my radar, because we just had a patient we were trying to manage with some hiccups. Yeah. Hiccups is a good one. I'm trying to figure out whether baclofen has a lot of good efficacy for neuropathic pain or not. So still out to learn more about that. So for drug-drug interactions, just wanted to go over some brief ones. So all of the skeletal muscle relaxants have an interaction with CNS depressants. It can cause CNS depression, and kind of with the concomitant effects that we see with all the other medications, we just want to be very careful with patients. Specifically outlined, carisoprodol, diazepam, methocarbamol, and metaxalone have specific drug-drug interactions with opioids, benzodiazepines, and barbiturates. and they can all increase the risk for respiratory depression. So making sure that when we're giving these, especially as part of a multimodal analgesic plan, that we're actually monitoring our patient's respiratory status and that we're aware that, we need to keep them well ventilated and making sure they can still breathe properly. For cyclobenzaprine and tizanidine, CYP1A2 inhibitors, so ciprofloxacin, oral contraceptives, verapamil, will interact because they'll all increase the serum concentration of cyclobenzaprine and tizanidine. And then specifically with tizanidine, it's found that oral contraceptives can significantly increase tizanidine effects. And this seems to be actually independent of the 1A2 inhibitions that oral contraceptives also do. And then diazepam, you need to be worried about CYP3A4 inhibitors and CYP2C19 inhibitors. And then carisoprodol, need to be thinking about our 2C19 inhibitors because we can have an increased risk for carisoprodol serum concentration, but also think about the 2C19 inducers, which would actually cause more mepropramate or the barbiturate to be in the serum. So I have a patient case. Patient PL is a 58-year-old male presenting to the emergency department with 9 out of 10 acute on chronic low back pain. He reports he has been having painful back spasms lasting for about 1 to 2 minutes, about 8 to 10 times per hour. He doesn't have any neurologic disease, and his home meds include venlafaxine and oxycodone, and he reports good adherence to these medications. His heart rate is 102, his blood pressure is 112/60, but all his other vitals are within normal limits. So what is our best initial antispasmodic for this patient? You have cyclobenzaprine, tizanidine, baclofen, or methocarbamol. You can go ahead and put your answers in the chat or unmute. See a D. Anyone else have a guess or an answer? D. Okay. I agree. D is the answer that I would pick as well. So cyclobenzaprine, I wanted to specifically avoid because of that drug-drug interaction that we have with venlafaxine. Tizanidine, his blood pressure is 112/60. So thinking about the hypotensive effects that we can see with tizanidine might make his blood pressure a little too soft. So something we want to be aware of. And then baclofen, because this is more of a muscle spasm, so it's our antispasmodics that we want to use, not our antispastic agents. I wouldn't use baclofen here. So I agree that methocarbamol is the best option here. Again, just monitoring respiratory status with the oxycodone use. So for some clinical considerations, I just kind of put this on here to briefly run through, but these are things that I think about for specific patient scenarios where I would choose these specific agents. So patients that are NPO, we have good options, and it depends on the institution, about IV diazepam or IV ribaxin. I've noticed that IV ribaxin is not at too many institutions, but it's been very helpful at the institutions that I've seen it used. For patients that are on antidepressants, I'd recommend going with methocarbamol. Diazepam can have some interactions with antidepressant CYP inhibitors. Cyclobenzaprine can increase the risk of serotonin syndrome, maybe even QT prolongation with some of our other agents like Lexapro. Patients with concomitant anxiety, I think diazepam would be a really good choice because it treats both the spasm and the anxiety. Patients with QT prolongation or on QT prolonging meds, methocarbamol and diazepam would probably be preferred here. Patients on opioids, benzos, or barbiturates, this is where you can use a bunch of the skeletal muscle relaxants, but you just need to use them cautiously. But because of the lack of interactions, I said tizanidine is probably the best one to use, but still have caution due to the sedation effects we can see. And then cyclobenzaprine if tizanidine is contraindicated. For patients with renal dysfunction, cyclobenzaprine, methocarbamol, and diazepam are good options. And for patients with hepatic dysfunction, methocarbamol is a good option. For elderly patients, I put tizanidine here and to use with caution. I think personally, I would prefer methocarbamol just because it doesn't have the anticholinergic effects and we can titrate it. Not too worried about blood pressure or other kind of issues. And then for spasticity, this is where kind of think about our antispastic agents. Think about baclofen, diazepam, or tizanidine. So I included these two charts, thinking about antispasmodic agents, what are our big clinical pearls? So with cyclobenzaprine, thinking about that dose decrease in elderly patients, only giving it maybe once daily, maybe twice daily. And again, 5 mg dose is as effective as a 10 mg dose. And then thinking about our anticholinergic effects that we see with cyclobenzaprine. For methocarbamol, I think one of the big things here is that it doesn't need renal or hepatic dose adjustments, even though you can have some higher serum concentrations. It's easy to monitor and haven't really seen too many deleterious effects. It also is probably the least sedating of any of the skeletal muscle relaxants, but you can still have some hypotension and discoloration of urine and feces. For metaxalone, I think it's important to note that while this is a pretty well tolerated medication, it can have that increased risk for respiratory depression. So making sure that we're aware of that, and that food increases its bioavailability is important to know as well. For carisoprodol, I don't personally have a lot of experience with carisoprodol specifically, but I think the biggest thing to know here is that it metabolizes to a barbiturate-like compound via 2C19. So make sure that we're aware of any of those interactions. For our antispastic agents, I put tizanidine and diazepam on here, even though they fall into both categories. Or for baclofen, thinking about that it can cause dizziness, urinary retention, also has a small chance to decrease the seizure threshold, making sure that we're aware of any withdrawal syndromes or symptoms or syndromes in baclofen. For tizanidine, thinking about the significant renal impairment dose adjustments that we need, so starting at 2 mg daily if severe renal impairment, and then also thinking about hypotension, LFT and elevations, and the fact that the tablets and the capsules are not interchangeable. For diazepam, I think the biggest thing is thinking about delirium. It's a benzodiazepine. It has an extremely long half-life, and then we have to think about the drug-drug interactions that we have. And then dantrolene, I didn't specifically talk about dantrolene, but I did add this on here just for completeness. So just to kind of summarize, our antispasmodics and our antispastic agents are unfortunately not interchangeable, specifically for musculoskeletal spasms or spasticity, because they actually target different areas within the different pathophysiologies. All antispasmodics are equally effective. We just really need to choose the one that we want to give to our patient based upon both our agent-related and our patient-related factors. And then skeletal muscle relaxants are commonly sedated. They can have a lot of anticholinergic effects. And they can be drying, so we need to make sure that we're properly monitoring our patients for any side effects with these medications. So that is all I had for skeletal muscle relaxants. I'll gladly take any question or any comments that anyone has if they've had any clinical pearls to share from their experience and practice with these medications. All right, well, if no one has any comments or any questions, thank you all for joining. Hope you all have a good rest of your day.